This one's a hot topic. GLP-1. Is it safe? What's it made of? How does it work? What are the side effects? Are they permanent? There's a ton of questions. I don't even want to eat up any more time. I just want to get to asking. I'm Sarah King, and I have a lot of questions. In this show, I get to ask WakeMed doctors any question I want, and bless their hearts, they have all the answers. Sarah Has Questions is a production of Mix 101.5 and Capital Broadcasting Company, and it's presented by WakeMed. Today's a big topic because I know in my friend groups, once this gets brought up, everybody has a ton of questions. And in fact, I have messaged every one of my friends groups and asked them what their questions are on this subject because so many people are so confused. And we're talking GLP-1 today, which is the miracle weight loss drug, also the miracle insulin drug, which I think held that distinction first. We are talking to Dr. Soboeiro, who is a primary care physician with WakeMed. Welcome back. Your third time? Third time. Oh, man. Yeah. Gonna get you a robe here soon. Charm. That's right. So you actually are the one who said you were willing to speak about this because we've asked a few people and not everyone's been willing to speak about this. Right. Why do you feel like you're an expert on this?
So I am a primary care physician, but I also did diabetes research and obesity research for many years. Don't do it anymore, but did it for many years. And really the focus of that was GLP-1s because as I came on the research scene, so did GLP-1. Okay. So the majority of studies that I shepherded were GLP-1 studies.
Okay. What exactly is a GLP-1?
Okay. So first let's go to what is GLP-1 as opposed to what is a GLP-1.
Good to know.
GLP-1, glucagon-like peptide 1, is something that you and I and every other human makes every single day.
Okay.
Every time you put food in your mouth, GLP-1 is secreted from your intestine, and it sort of sets the stage to absorb the food that you're eating. When you start eating, GLP-1 tells the pancreas to start making insulin. It tells the pancreas to start turning off the production of glucose. It does all kinds of things to ready your body to absorb what you're eating.
Interesting. And you said it's glucosamine-like?
Glucagon-like peptide 1. That's just the name.
So how does taking an additional GLP-1, additional GLP-1, how does that result in weight loss if you're automatically making it in your body?
Sure. So that's a fascinating question, right? So we started studying GLP-1 because we knew they caused insulin to be secreted and because they suppressed glucagon. And both of those things are really good for type 2 diabetics, right?
What's glucagon?
Glucagon is the peptide that the pancreas makes that makes us produce glucose. Okay. So when we eat, insulin gets produced to metabolize the glucose we eat.
Right.
When we don't eat, the pancreas makes glucagon, which makes the liver make glucose, so we don't die or pass out when we're not eating. So we can go for hours and hours without eating because glucagon tells our liver to make glucose. Our liver makes glucose, and there's enough glucose for us to survive without eating.
Interesting. Yeah. Okay, so how does this medicine work then?
So what we found years ago is that type 2 diabetics don't make effective GLP-1. It's not that they don't make it, but the GLP-1 doesn't work, okay? But when we give them pharmacologic doses, so much higher doses than physiologic, than what the body would normally make, it can overwhelm that and it can make the GLP-1 work like somebody who doesn't have type 2 diabetes. So it makes them produce insulin, it makes them suppress glucagon, it makes the diabetic have all the factors going on that the non-diabetic would have.
Okay.
And then we found this really interesting thing. There are GLP-1 receptors in the hypothalamus of the brain that tell us to stop eating. They cause us to feel full. And again, the physiologic reason for that is once you start eating, the body's getting you ready to go, okay, I'm full.
That's enough.
That's enough. But what we found is that made people feel full and stop eating. And that's where the whole weight loss part came from. The early GLP-1s that were produced didn't have this huge effect on the hypothalamus. But when we got to the later stages of the Semaglutide that we have today, the Tirzepatide that we have today, those receptors in the hypothalamus of the brain had this large affinity, and so they really caused patients to feel full, which is how they became weight loss drugs.
So As far as diabetes goes, though, so did everybody who took this drug as a diabetes drug lose a bunch of weight? Like, isn't it dangerous at a certain point because they have to be on it forever? So does that mean they're going to feel too full for too long? Do you understand that question?
Yeah, no, I do. And the fact of the matter is that almost everybody reaches a plateau. I mean,
Okay.
some patients don't lose that much weight. Interestingly, the thinnest diabetic patients really didn't lose a lot of weight. They still had all of the positive effects of GLP-1 on their diabetes, but they lost much less weight. But the heavier patients lost more weight. But everybody plateaus. And whether you use these drugs for weight loss or diabetes, I mean, everyone plateaus after a while.
Because your body recalibrates.
Exactly.
Okay.
Exactly.
How long have has these synthetic versions of GLP-1 been around?
So the first GLP-1 came to market in 2005, Exenatide.
That's
And
relatively recently?
Relatively recently, but I mean, we've had 25 years of study with these drugs.
Okay.
So 25 years is good because you know if you've been studying a drug or a category for that long, you kind of know what it's going to do. You know the side effects. So you feel very comfortable telling people what it will and won't do.
Is that why it got approved for weight loss? Because to me, it just feels like it came on the scene, like, 4 years ago at this point? I'm guessing, I actually don't have that date in front of me, but it feels like around 4 years ago, and it just took over.
I mean, it's a little bit longer than that. So maybe 8 years ago or so.
Really?
The older GLP-1, so liraglutide, which was Victoza as a diabetic drug and Saxenda as a weight loss drug, that got approved. And that was a decent weight loss drug, but didn't have the same affinity for those hypothalamic receptors, right?
Right.
But then when we got to Semaglutide in the later versions, they were much stronger weight loss drugs. When you started hearing about it,
was Ozempic.
Ozempic, right? So Ozempic was a diabetes drug, and people figured out that they were losing bunches of weight, and
Right.
then it got into the public consciousness.
Right. Okay. Now let's talk about these studies. I'm just going to ask it point blank because I think it deserves to be asked. Has it even ever been studied in women? Because up until the past however many years, nothing was studied in women.
So, I think I can say that the medical research groups, medical research institutions have tried very, very hard in the last 20 years or so to make sure that studies include women and men, that they include all for different age groups, and that they include people from different ethnic groups.
Excellent.
So that when you bring something to market, you can say, this was studied in all different groups, not just a bunch of
White guys.
white men.
Yeah,
Right.
exactly.
Right.
So does that mean that your answer is yes, it has been studied?
My answer is that in most of the studies that I've seen or taken part in, there were equal numbers of women and men.
Excellent. Okay. So in those studies, do they make sure that they've studied it in women's fertile years, in their perimenopause, and then postmenopause times? Because a woman's body might as well have 3 different bodies. That's how much we change in those time periods.
In the studies that I've been involved with, there's been no specific look at, how people tolerate it during this period or that period. But I will say that the age ranges were large. Typically, the age ranges were 18 to whatever,
Sure.
80s.
Okay.
So I mean, it was definitely studied in people in all of those age ranges.
Just not specifically written
Specifically,
down, this
right.
is why we're doing it.
That's correct.
Okay. All right. Now, this is something, and like I said, I asked so many people because I know a lot of people who are on it. I know a lot of people who are terrified of it. And there are all these rumors going around, and most of them involve side effects. Why don't you tell me what the side effects are, and I'll see if they're on the list of the ones I was given.
Okay. So the true side effects of these medications, and again, we've studied this for a long time, are gastrointestinal. The medicines slow the absorption of carbohydrates, and they slow gastric transit. Okay? So think about that, and you can sort of predict the side effects. Some people get nausea. Some people get constipation. Some people get diarrhea. Almost all of the side effects are GI related.
Okay.
The true, what I think are the true side effects of these medicines.
And do they last forever?
No, most of them, if you look at the studies, most of these side effects go away in the first 8 to 12 weeks. Now, there certainly are patients that never tolerate them. I mean, that's true of any drug.
Well, that's what I was going to say,
Yeah.
because I do have some stories of people who she had stomach paralysis, went off the drug. She still has stomach paralysis. But I mean, she must be an outlier based on what you just said.
Yeah. I mean, you can't speak to every single situation, right? But if you look at the studies, about 10% of people get any nausea, GI side effects at all. And the majority of that, I'd say 80%, go away in the first 8 to 12 weeks.
Okay.
So you're looking at a couple percentage of patients who just don't tolerate them.
Right.
Yeah.
Okay.
Now, that's really the main group of side effects. What I hear all the time is about muscle loss. And the reality is that if you or I lose weight using a GLP-1 or using a diet or using exercise or using anything else, we're going to lose both muscle and fat.
Yeah.
And it's incumbent upon us to eat right, eat enough protein, and exercise to prevent muscle loss. I don't believe these drugs cause any excess muscle loss over any other way of losing weight.
Okay. That's great. I've had, so stomach paralysis was on here.
Yep.
Pancreatitis I've heard a lot about. And so is this like an outlying situation where like outliers may develop pancreatitis?
The majority of these studies have been done in diabetics. Diabetics have more pancreatitis than non-diabetics. It's very clear. Diabetics have 3 times the rate of pancreatitis of non-diabetics. So the question in all the studies is it the drug or is it the
diabetes?
disease? And all of the looks at that have felt that it is the disease, not the drug.
Got it.
In fact, most gastroenterologists will tell you that, if somebody has pancreatitis and you know why they had pancreatitis, it's okay to use the drug. If somebody has pancreatitis and you never figure out the cause, and for safety's sake, you might not use the drug again. But it's not my belief that these drugs really lead to pancreatitis.
Okay. How about gallstones and kidney issues?
Sure. So gallstones, again, anything that causes you to lose weight and eat less and hydrate less are going to increase the risk of gallstones a little bit,
I don't
right?
even know what a gallstone is.
Well, gallstones are, it's the bile that you make to absorb fluid that
Got
gets
it.
stored in your gallbladder.
I see.
And if it gets dried out, it can form these stones that block off the neck of the gallbladder and then cause you all this pain and stuff.
Got it.
But gallstones happen in people on diets that have nothing to do with GLP-1. So again, really an effect of weight loss as opposed to specifically the drug.
Okay. What about the kidney issues? Same thing?
I mean, all I'll say about kidneys is that these drugs have been proven to benefit the kidneys. Now, there have been some cases where people get dehydrated on these drugs because they're not eating and and their kidney function deteriorates, usually transiently, but they are not kidney toxic. These drugs are actually very helpful to prevent kidney disease, specifically in people with diabetes.
Okay. Oh, go ahead. Please continue.
No, well, I mean, it's just, as we've studied these drugs, and you know this, we've seen all of these other benefits that have been serendipitous. The decrease in the rate of kidney disease, the decrease in the rate of liver disease, the decrease in heart attacks and strokes. They're pretty amazing drugs for diabetics.
Oh, yeah. And so is it safe to say that you're speaking mostly to the diabetes side of things whenever I'm asking these questions? How much has it been studied for weight loss?
So the weight loss studies are now, there are all kinds of weight loss studies now. But I was involved in a very large study called SELECT, where we took people without diabetes who were overweight but not necessarily obese, okay? But they didn't have diabetes, and they had a cardiovascular event. They'd had a heart attack or a stroke or peripheral vascular disease, something like that. And then we followed them forward on the drug. And what we found is that group had significantly fewer heart attacks, strokes, vascular disease going forward. So even if you weren't diabetic, the drugs prevented that next cardiovascular event.
Okay, we're going to get to the benefits here in a second. Libido is someone I know who's on it asked about it. One of my friends said, well, ask him about libido. Does it increase it? And I was like, well, if you're looking thinner, it might make you more, randy. But so what have you heard about?
I'm not aware of any data that suggests clearly that it has any effect on libido, either positive or negative.
Okay, let's talk about the unexpected positive side effects. So you were saying kidneys are functioning better, liver is functioning better. I've heard addiction cessation is an unexpected event or effect. Can you speak to that?
Yeah, there are GLP-1 receptors all over the body. There are GLP-1 receptors in the brain, in the pancreas, in the heart, in almost every organ. So you're starting to see some of these serendipitous effects. Some of it has to do with the fact that they decrease inflammation. And I think you and I talked about that a little bit before.
We have.
But when you decrease inflammation, you can decrease, cardiac events, you can decrease kidney disease, you can decrease fatty liver disease. So there's a lot of benefit there.
Right.
But yeah, there are studies now in addiction and depression and in a number of different things. And a lot of that hasn't come to fruition yet. We haven't seen the results of the studies. But the short-term, early studies are promising.
Oh, okay, great. Yeah, and I was going to ask you about that depression. I hear one of the big things from my friend, I used to have an eating disorder. I'm a survivor, and so is she. And she says it canceled out all the food noise for her once she started this. And I was like, well, is that because you're losing weight so you don't have to think about it anymore? Or is there something more to it?
Well, when I hear patients say that, and they have said that cancels out the food noise, I always assume that means I just don't feel that hungry. I just don't feel that excited to eat.
Maybe.
And I'm assuming that's the satiety part. But I don't know beyond that. That's an interesting question.
Yeah, because she's like, it's one of the things, because I always have, what food noise for me, it just means the guilt involved with eating.
Interesting.
No matter what I eat, I feel guilty. And she said she used to feel the same way. And she's like, that's all gone. And I'm like, I don't know. You're losing weight, so maybe that's why. But anyway, maybe you want to put that in your study bucket.
Yeah.
And another one that was interesting that someone asked me, and I didn't even think about this, was Alzheimer's, that it's been shown to help with Alzheimer's. Is this true?
I don't think there's any definitive evidence. I mean, again, there are studies.
Right. They're working on all that.
Yeah. And inflammation is involved in so many different processes.
Sure.
That if you decrease inflammation, that's the idea, that there may be positive effects in these diseases that to some extent are caused by inflammation.
Yeah. So there are a lot of different brands. We're going to change gears here. There are a lot of different brands of GLP-1s at this point. A friend of mine who's on it says she could tolerate certain foods on one but couldn't tolerate it on another. So how are these drugs differing?
Sure. And I think, to make it easy, first of all, there are the drugs for diabetes and there are the drugs for obesity, for weight loss. They're the same drugs. They're named differently, and insurance treats them differently. It's much easier to get them covered for diabetes than it is for weight loss.
I've heard that from everybody.
That's the reality of our situation right now.
I wonder why.
Well, and I think the sense is that diabetes is a medical issue.
Sure.
But I think what it really comes down to is that if everybody with obesity got treated with these drugs, where would the money come from? I mean, I think that's the reality. And you and I talked about this the last time, too. These are the best pre-diabetes drugs ever.
That's exactly what I was getting ready to say. It's called preventative medicine, is it not?
I mean, if you truly were not looking at money, almost everybody with pre-diabetes should consider these drugs. But that's another story.
That's a whole nother, that's rage bait.
There are really two drugs right now that are being used for obesity and diabetes.
Okay.
Semaglutide and Tirzepatide.
And they're both GLP-1s.
They're both GLP-1s. Tirzepatide, actually, that's the newest one, so you've probably seen that as Mounjaro or Zepbound.
Yes.
That's actually technically a GLP-1 GIP dual action drug. Basically, they're agonists of two different hormones.
Okay.
And that's actually, if you want to talk about where we're going, that's what you're going to start seeing. You're going to start seeing drugs that either antagonize or agonize multiple different hormones that affect satiety or hunger.
So I would imagine that means boost or block.
Right.
Okay.
Right. I mean, typically these are they're boosting satiety hormones.
Right.
But there's also the possibility down the road that they could block the ones that make us hungry.
So what in those drugs, where they differ, how does that affect specific foods, or do we not know that yet?
Yeah,
the fact that you want you like one of them makes you nauseous, and then you take a different drug and that same food doesn't make you nauseous anymore. You know what I'm saying?
I don't think there's really any data to say, well, this drug does this with this food or this drug does that with that food. As I said, one drug affects two hormones, one drug affects one hormone. So you could see that there might be a difference.
Yeah.
And Tirzepatide you've seen more weight loss on average than you have with Semaglutide. I mean, they both work, but I think, one of the reasons you maybe see more weight loss is because it affects two hormones as opposed to one.
Yeah.
But I mean, I can't look at you. Oh, you want to eat bananas? Well, we need to give you this one.
Yeah. I just find it interesting, and I'm like, why would that even happen?
Right.
Wegovy now comes in a pill.
That's true.
Which is exciting for people who are afraid of needles.
It is.
But how does it make any difference as far as the drug's efficacy or in any way at all, really?
Yes. So it is very hard to get these drugs absorbed orally. Okay, that's why they haven't been oral until now.
Why is that? Is the molecule too big?
It just gets absorbed in the stomach, and it doesn't get to the bloodstream. Okay, so the way that it's done right now is it's paired with an absorption enhancer that's taken orally, but you have to have perfect absorption conditions to get the oral drug absorbed. So what that means is you gotta put the drug at your bedside with 4 ounces of water, wake up, take the pill, take the water, do not eat, do not take any other medications for half an hour. You've got to optimize absorption conditions. And even then, the absorption rate is 1%. So 1 of 100, 1 milligram of 100 is going to get absorbed.
Wow.
So you're taking a much bigger dose of drug orally than you are injectably. The fact of the matter is, I mean, for patients who cannot take injectable drugs, it's fine, but it's more efficient right now, given what we have pharmacologically, it's more efficient right now to take it injectably.
Yeah. Well, that's fascinating. And also sounds like a chore. Sounds like a brand new job.
It's easier. The injection, if you've done it or seen someone who did it, and you pull it out of your refrigerator, boop, 10 seconds once a week.
Yeah. But some people really they faint at the sight of a needle.
That's right.
Are there any people who are ineligible for GLP-1?
So we talked a little bit about side effects. There is a black box warning on the drugs that's been there for 20 years, and it talks about medullary thyroid cancer. Now, medullary thyroid cancer in humans is extremely rare. It's less than 1% of thyroid cancers. In 30 years, I've seen one patient with medullary thyroid cancer, to give you a sense of how uncommon this is, right?
Sure.
And the fact of the matter is that this was seen in rats and mice in early studies, not in humans. Rats and mice have very different thyroids and parathyroids than humans do.
I would imagine.
Okay. But the problem is it's so rare that they haven't been able to prove the negative, specifically prove the negative. Well, we've seen so many cases that there just isn't medullary thyroid carcinoma caused by these drugs. So they've left that warning up there. But I think practically it's not
something to worry about,
right?
Yeah.
I mean, so you asked who can't take the drugs. Well, if you've had medullary thyroid carcinoma, again, that is not all thyroid cancers. 99% of thyroid cancers are not medullary.
Yeah.
If you've had that, if a family member's had that, if you've had this genetic syndrome called MTC, you can't take the drugs. But that's a tiny number of people.
Yeah, and even if you did have it, it sounds like it still may not cause it because it caused it in rats, right? Is that what you're saying? Yeah.
Exactly.
I have heard that GLP-1s eat bone density. These are rumors. I'm giving you everything that people asked. So this is what's going around.
I think that's something that's more understudy. I don't, and I haven't seen all the latest research, but I don't think there's a huge amount of evidence on bone density outside of the fact that when people lose weight, you have to make sure they exercise, they get calcium, especially women, so that their bone density doesn't suffer in that situation.
Okay. And this is a really big one that most people asked, which was, what happens when you stop taking this medication? Are you going to bloat right back up, or do you get a new set point? Because in my mind, when I consider taking it, I'm like, well, let me lose this 30 pounds that came on with perimenopause, and maybe I'll gain 5 pounds back, but it's not 30. Or will I just go right back up to where I was when I started?
Sure. So the first thing to say about that is, if you lose weight for any reason, okay, your body tries to defend your weight. Your body tries to get back to the weight you were at. Why does it do that? Think about it from an evolutionary standpoint. When we started to lose weight, we couldn't reproduce, and then we died, right? I mean, that's what happens when the organism starts to lose weight. So your body defends that weight. Now, let's say you go on a diet for 8 weeks and you lose some weight. And then we measure your hunger hormones at 8 weeks. They're going to be elevated. Your body has elevated your hunger hormones so that it can defend your weight.
Right.
Okay? Now, let's say we measure them in another 8 weeks. They're still elevated. Let's say we measure them in another 8 weeks. They're still elevated.
Right.
The hunger hormones stay elevated way past that diet you went on. So that's the underlying principle. It's not drug or no drug. It's what the body does. That's why weight loss is so hard, period.
No one's ever put it that succinctly before. That's the problem. Does it ever go down?
So, yes, we think so, okay? There is a theory called the fat mass set point theory. And again, this is fairly thin on data, but we believe that over time, your body can reset.
How much time?
Well, that's what's unclear. But when patients come to me and they say, I want to take this for 3 months, I'll say 99.9% of the people are going to gain all the weight back at 3 months or 6 months. That's just what we see. If you really want to have sustained weight loss on this drug, you need to think about 2 years. I always use 2 years.
Okay.
And there's no guarantee at 2 years, but to me, that's giving your body a chance to reset. And we've all known people who truly have reset. I mean, long before these drugs, people who lost weight, who changed their diet, who changed their lifestyle, and then didn't have a weight problem anymore. I think that's a manifestation of this same idea, this fat mass set point theory.
Yeah, that's fascinating.
But that's why I tell patients, look, if you really want to do this, I want you to think about doing it for the long term. And think about the cost of doing it for the long term, because if you really want benefit, that's where the benefit is.
It's good. And we're not even sure. Are there even studies on that, like this new theory that you're talking about?
There's nothing clear and definitive. And there's also not a clear definitive time. But, I believe based on what I've seen, based on the studies I've seen, it's a lot closer to 2 years than it is 3 or 6 months. And that's just the reality. You asked me in the questions, where are we going with this? Are we going to get better GLP-1s? I actually think what we're going to get is we're going to get different hormones. There are a bunch of satiety hormones, and there are a few hunger hormones. And I think what people are looking at right now is how to affect those other hormones. And then what you're going to see is you're going to see combination drugs that go after multiple hormones. And I think you're going to see drugs, and a lot of the early studies are showing this now on drugs that haven't been approved yet, that are really fantastic at getting weight down because they're accessing multiple hormones.
And the hormones is like a new thing. This is like new science, relatively speaking, correct?
Well,
as far as like what this, like the idea of blocking a hormone as opposed to what fen-phen did, whatever the heck fen-phen did, which wasn't good and killed people. Like this seems like a much safer route. And it seems to me like it's rather new, or am I totally wrong on that?
No, I mean, relatively new. I mean, I think we've gone after hormones for years. The satiety hormones, maybe 15, 20 years.
Right.
But I mean, it's new, and we're starting to learn how to affect these hormones. And the last thing I'll leave you with is one of the systems that you're going to see, I think, affected as part of these drugs is the cannabinoid system. Now, cannabinoid, right?
Does that mean marijuana?
Cannabis, marijuana, right? So what happens when you use marijuana?
You get the munchies, yeah.
Right? So what happens when you antagonize that receptor?
You don't get the munchies.
You get the opposite. We actually studied this back in the early 2000s.
Did you get people high?
No, the drugs didn't get people high. In fact, the worry was the opposite, because you're antagonizing those hormones. And actually, the studies got stopped because there was some concern about depression. But when they looked back at the data, they said, there's really not a whole lot of clear depression there that's caused by these drugs, and we have better, more targeted ways of targeting the cannabinoid system. So let's look at that again. So the companies are looking at the cannabinoid system again as part of these weight loss cocktails.
Well, I mean, given the fact that this works so well, so let me ask you, so let's say you were 30 pounds heavier, which you're not, you're a very fit man. Would you take a GLP-1?
I think they are very safe drugs. I think they are good weight loss drugs. They're amazing diabetes drugs. I would take one. If I needed to take one, I would take one. I've spent enough time with these drugs to feel very comfortable about their safety.
Okay. That's the bottom line, in my opinion. Well, thank you so much. I've been waiting to do this episode. We didn't touch on insurance, which I know a lot of my friends asked me to talk about. And I was like, I have a feeling he's not going to want to get into that. And also, we didn't talk about marketing and the sociology behind it. And so there may be other podcasts in that. But as far as like nuts and bolts, how they work, why they work, and who they're for, this was super informative. Thank you. Whew, I had so many more questions. I think I'm going to have to do another episode, especially about the psychology bit. Also, before I go, Dr. Soboeiro wanted to mention that compounding pharmacies are something you want to avoid when it comes to GLP-1s. There are a lot of bad players out there putting things that don't even involve a GLP-1 in there, or maybe even dangerous items in there, then that might be where some of these side effects are coming from. So it's just best to avoid a compounding pharmacy. Yes, it's less expensive, but it's not safe. And he really wanted me to mention that. So get the real deal, guys. Thanks to Dr. Soboeiro for taking the time and answering all my questions. And if you have any questions, have an idea for a topic, send a message to us on Instagram. Sarah has questions. I'll see you next time, guys. Be well.